Hello, everyone. It's Roger Hartle in New York. I welcome you to our Neurotrauma course, the 7th annual Neurotrauma course with our colleagues, esteemed colleagues and friends in Tanzania. Before we get started, I want to just give you a short summary of our relationship between Weill, Cornell and Tanzania, which is a very special and very precious relationship that started in 2008. And we've established this relationship to the point where now we have weekly interactions, we share fellows, we work on research projects together, and our relationship has really resulted in many valuable and wonderful experiences, I think, for both of us, for the Tanzania surgeons and the staff over there and here in New York. Today, though, we want to introduce our 7th annual Neurosurgery, Neurotrauma, and Critical Care course. We started this many years ago, and the tradition has really been obviously to do a in-person course in Tanzania. This year, this is not possible. However, because of the amazing talent and the amazing initiative from many individuals across in Tanzania, but also here, we've been able to put together this online webinar. We've got an amazing program. You probably saw that online. Before we get started, and before I hand over to Dr. Shabani, who's the neurosurgery chairman at MOI in Tanzania, I want to thank the local team very much here in New York, Roseanne and Tatiana, and our student Brenton, who have been working tirelessly to really put this together from a technical and organizational perspective. I want to thank the local organizers in Tanzania, led by Dr. Shabani, Dr. Magogo, and their team. The international co-organizers, Beverly, who is currently in Kenya, who was one of our fellows in Tanzania, who did a fantastic job there. And I want to also thank Dr. Hal Mangat, who's a neurologist who's been co-hosting this symposium for many years, who's currently in Europe. So that said, I don't want to take up more of Dr. Shabani's time. I want to hand over to Dr. Shabani. I know he's with the local troops at the conference hall at MOI in Tanzania. Thank you, Dr. Shabani. I'll unshare my screen and I'll hand it over to you, and I wish you success. All the best. I'm
Hello, everybody.
excited about the program.
Thank you very much, Professor Hartle, for continued support of neurotrauma course in Tanzania. First and foremost, I greet everybody all over the world. Good morning, good afternoon, and good evening. I know for sure we have 600 something applicants who are applied for this course all over the world. And we welcome you all to this course. This year, as Professor Hartle said, it is going to be virtual. But in all these 6 consecutive years, the course has been practical on the ground and accredited by our Regional College of Surgeons of East, Central, and Southern Africa. So you can find this course announced every year in the website of COSEXA, apart from other websites of Cornell and our collaborators, WFNS and the rest. The second thing, I'm standing here on behalf of the Executive Director of the Muhumbili Orthopaedic Institute, who greeted all of us. He couldn't be with us here because of the other commitments, and he commended our cause to keep on. Lastly, I thank all of members who have accepted to attend to this course, and I hope this is going to be a very fruitful discussion, and welcome you all.
Thank you, Dr. Shabani and Dr. Hartle for the welcoming word for this particular meeting. I would like to start with our first session, which is the update of TBI Global Perspective. And we are going to hear again from Dr. Shabani and the rest of representatives about the global perspective of TBI, as well as we are going to, in this particular session, we are going to discuss case-based discussion led by team from MOI of the TBI patient. And finally, from this section, we are going to have the COSEXA member panelist for the discussion of the cases. So I would like to call back Dr. Shabani to start the presentation.
Yes, I'm back again. I was asked to present on the Peshawar Declaration. Actually, it is called Peshawar Declaration. I don't know whether it has been adopted like that. It was coined that way because this paper was presented in the ICRAN conference last year in Peshawar after a diligent work which was being done for years before that. But this paper is published in the Wellbeing Neurosurgery 2019 with the topic named Comprehensive Protocol for the Management of Traumatic Brain Injury and Spine in Low and Middle Income Countries. So to begin, let's see how it started. The World Health Assembly in 2015, during the SDG protocol, it emphasized surgery as a means of improving health and lowering mortality. At the same year, the Lancet Commission on Global Surgery report, it emphasized the importance of the surgery in lowering the mortality. And this is how the National Surgical Obstetric Anesthesia Plan started all over the world. The Lancet report in brief, this is what it mentioned. It mentioned about 5 billion people don't have access to safe, affordable surgical obstetric anesthesia care we needed, and 143 million additional surgical procedures are needed in low and middle income countries each year to save life and prevent disabilities. 33 million individuals face catastrophic health expenditure due to payment for surgical obstetric and anesthesia care each year. So, in conclusive, invest in surgical services in low and middle income country, which is affordable, it saves life and promotes economic growth. This is the Lancet report of 2015. And if you look, Tanzania also jumped on the bandwagon to develop her own national surgical obstetric and anesthesia plan. And if you look into all these NSOP plans, there are 6 components which have been put into framework. Number 1 was infrastructure, and then workforce, service delivery, financing, information management, and governance. And if you look into detail of each component, you will see they are talking of things which have already been invested. Infrastructure, for instance, they are talking of surgical facilities to extend to all the levels up to the referral levels. And to be more precise, the readiness for blood supply so that surgeries can be attended. And the workforce, they were emphasizing on the anesthesia and obstetric providers. The surgical, yes, it was mentioned in that document, but if you look into the surgical procedures, there was no mention of neurosurgery. This is what is missing in this document. And service to delivery, they are also talking of emphasizing the general surgery, not neurosurgery. That's why it was necessary that this National Surgical Obstetric and Anesthesia Plan be modified to suit our neurosurgical needs. If I bring you back again, in 2001, Journal of Neurosurgery, where Professor El Hamlichi from Algeria, from Morocco, I'm sorry, published his paper on African neurosurgery. This is what he said. There's positive data in terms of equipment, resources, human capacity, and neurosurgery. And he noticed that there were 4 categories in terms of development strategies, development strata. There are those who completely had none of all the 5 categories they were analyzing. And there are those who were much better, up to level 4. I think level 4 included Egypt, South Africa, Morocco, and some other countries. And then he noticed also for those which had fair better neurotrauma, had fair better stratification. Neurotrauma counted high in the neurosurgery workload. And training and equipment was necessary. And this is, if everybody remember, this is when the WFNS started with the Africa 100 program after this. If you also look into 2016 WFNS survey on global neurosurgery workforce, you will see Tanzania is ranked at that data I'm showing you, 0.015 neurosurgeons per 100 population distribution. Now compare this with affluent countries like Japan, 7 neurosurgeons per 100,000 population. You will see that there's an inadequacy of neurosurgical services. If you put all this together, it means something is alarming for low and middle income countries. If you check again, this paper, a systematic analysis on global burden of disease, which was written by Hideaki Higashi from Japan, he mentions very categorically on this table 1, road injury and transport injury and falls. All these are trauma, major components in surgery. And if we control that, we are going to avert the burden of surgically remediable causes of mortality and disability. And mind you, 25% of this burden is in sub-Saharan Africa. Again, in the global burden of disease, trauma injuries constitute 11% of the global burden, majority in the low and middle income countries. 11% is a higher figure, surpassing the ranking for HIV and breast cancer included together. So it is important. And Michael Dewan, who is the author of this paper we are talking about today, this is what they found in their survey with Professor Kipak, that global neurotrauma burden 22.6 million, only half require surgery, higher proportion in low middle income country, and 5 million cases per year. This underscores the importance of neurosurgery to be included in the National Surgical Obstetric and Anesthesia Plan. Now, the issue here was not to reinvent the wheel, but was to modify and see what we have on the ground. Different strata of development, as Professor Hamlichi reported in 2001 paper. And then ongoing projects, which are scattered into different levels. And mind you, here we are talking of trauma. So, a consultation was sought from American Academy of Surgeons from their trauma management policy document. And this framework was was adopted to be included in the NSOP strategy, which was actually rolling at that time. And our lead team was KPAC, Tariq Khan, and the WFNS Neurotrauma Committee. And the valid testing was done through advisory meetings in Cambridge, UK. That was the first meeting. And then the second meeting was in New York, 2019 in January, I remember. I attended the meeting. Professor Hato was also there. Thank you, Professor Hato, for your comments in that day. And then the final announcement was announced in Peshawar, Pakistan, later in December 2019. So what does it entail? Here I'm going to show you very briefly. Never mind about this matrix. It is too complex. But when I keep talking, you all understand. What you see on the left column, this is the framework as designed by WHO National Surgical Obstetric Plan: infrastructure, workforce, service delivery, financing, information management, and governance. And then the other one which you see on the top row column, this is what was adopted from the American Academy of Surgeons trauma protocol: surveillance, prevention, pre-hospital care, surgical system, and rehabilitation. So we included this matrix together so that it can be comprehensive and to be inclusive of all the strata of development in LMIC, because one shoe cannot fit all in terms of neurosurgery in this LMIC. So anyone can start at any entry point. For instance, infrastructure, people can start with a surgical system, for instance. Others may start with pre-hospital care, depending on their environment and the investment they have, and I mean the capability and everything. And likewise, this goes all the way down to service delivery and everything, the workforce and the rest. An advantage of this matrix, if I can share with you, is that each LMIC country, based on her varying capacities, as I said, can adopt the recommendation. Very easy. And then it allows room for consolidation and sharing of experiences. And then the policy took into account the existing multifaceted neurosurgical programs currently ongoing, like in our region, the COSEXA region. We have FINS going with the projects. We have Weill Cornell going also with projects. We have Cambridge University also going with projects. South Africa also is coming in, you know. So all these programs can be consolidated and bring up about the targets which are listed in this comprehensive recommendation matrix for neurotrauma. And it gives collaboration, North-South cooperation. Thank you very much. Yes, just to get you back again, I didn't mention this course is endorsed by many organizations, including College of Surgeons of East and Central Africa, Central Southern Africa. It is also endorsed by AO Spine Foundation, and it's also endorsed by FINS, Foundation for International Neurosurgical Education. And yes, I will mention to you again, and it is going to get CPD points. It will be announced later when Beverly is connected. So whoever is attending will get a CPD point and a certificate. So please keep tuned until the last day of the course on 28th November. and you will be awarded a CPD certificate.
Thank you, Dr. Shabani, for those who have logged in. All those who are in the COSEXA region, if you submit the certificate to your governing bodies, certainly in Kenya, they will recognize it because of COSEXA. So there's a reciprocal arrangement about COSEXA approved courses within the region.
Thank you, Bev.
Thank you, Bev.
Thank you, Shabani, for the good presentation on the Peshawar Declaration. I would like to call upon Professor Hamis to present the after the Peshawar Declaration, the Nigerian perspective.
Not yet. Or maybe not. I guess not.
Sorry for the small hitching on the communication. I would like to give thanks to Dr. Shabani for the presentation and highlights on the Peshawar Declaration. Now, without wasting time, I would like to call upon Professor Amos Adeleye from Nigeria to present on the Nigerian perspective after Peshawar Declaration. So, Professor Amos, you're welcome to start your presentation. Hello? Hello, Professor Amos? Hello, Professor Amos, can you hear me? The mic is, eh?
Hello. Yes, hello.
Yes, we can hear, Prof.
Okay, so I've been having issue. Okay, share. First, my internet was. Yeah, good day, everybody. Good morning in New York. Good afternoon, good evening, the rest of the world. I wasn't at Peshawar, but as Dr. Shabani has hinted us, the declarations there have to do with a quantitization of the problems of the care for traumatic brain injury in the world, but I guess particularly in the low middle income countries of the world where we know there are challenges, infrastructure, and whatnot. So what I then chose to do was to do a quick overview of the care of the traumatic brain injury in Nigeria, as I know it, as a practicing neurosurgeon in Nigeria. Now, by the way, I don't see my slides showing, please, even though I've clicked on share screen. Are you seeing the slide showing cells and mass? Oh, what has happened now? I was doing well before. I don't see my slide showing that. Am I on? Are people hearing me?
Yeah, we can hear you.
Okay. Thank you, but I don't see the slide showing. Even though I have said that the screen should be shared, and it's, by the way, I have it dropped in the Dropbox. If Brandon can help me load that now, I guess, since I'm having issues with mine here.
I think you may need to close Firefox. It's opening up hundreds of windows.
Yeah, oh, okay. Firefox is the problem?
It appears like, I don't know, that's what it looks like, that you have lots of Firefox windows opening up.
Yeah, that's going to be a problem. Oh my. If I close Firefox.
Oh, there we go.
Okay. I see Brandon is helping me. Oh, thank you, Brandon. Yeah, I practice in the University College Hospital, Ibadan, Nigeria. I have no conflict of interest for this presentation. I'm trying to move the slide. Will you move? Brandon, do you have to move the slide for me? Yeah, this is the College of Medicine to the left where I practice of the University of Ibadan. And this is the University College Hospital, which is the University Teaching Hospital of this College of Medicine. Still the foremost university hospital in Nigeria, and neurosurgery birthed in all of Sub-Saharan Africa in my unit in 1962 by Professor Olatunde Odeku, who trained with Professor Richard Snyder in Ann Arbor, Michigan. This is a global map showing Africa. Oh no, please, previous slide. This is global map showing Africa, and this is North America. New York is somewhere here. This is Africa. Nigeria, in this slide to the right, which is showing Africa, sits in the crotch of the map, actually in West Africa, whereas Dr. Shabani is talking from this zone, somewhere here in East Africa. In the developing countries, as Dr. Shabani has had cause to talk about in some of his previous slides, there are logistics problems with caring for total medical care and certainly expensive neurosurgical care. Against the backdrop of healthcare that is privately funded with point-of-sale payments out of pockets for all in-hospital care by a patient population which are majority impoverished and live below $2 a day. So the delayed presentation and follow-up issue of concern. Nevertheless, traumatic brain injury can be a sizable portion of the average neurosurgical practice in all of Nigeria and certainly in all of developing countries. In one work we did in another institution that I worked before I ended up in my current position, we showed that head injury was about 1/5 of the total workload. The majority were males and young, mean age of 29 years, and are low-income earners in close to 90%, school children or unemployed, and a 3/4 of them by road traffic accident, with 3/4 also receiving some initial care in some peripheral hospital before they arrive in our units at an average of 33 hours. Next slide. Thank you. And that mild, moderate, and severe injury come in these proportional distributions that are shown here. A quarter of sustained other systemic injuries. At that time, we could only get cranial CT done in 40 patients, less than 1/3. And of these, out of the 9 that had surgical lesions that called for neurosurgical intervention, just about half of them could undergo this surgery for reasons of logistics impediments like I talked about before. And many of them had well-known determinants of poor outcome in head injury, which include anastocoria, deep coma, prolonged unconsciousness, seizure, hypotension, and so on and so forth. Next slide, please. Next slide, please. So the total care of primary head injury, the previous slide, sorry, you jumped, thank you. The total care of traumatic brain injury, as we all know, have to do with primary prevention, road safety, personal protection, helmet, seatbelts, and statewide legislations, including what policies govern what manner of people are licensed to drive vehicles, to drive motorcycles, and road engineering that also try to afford traffic calming measures and all that. And then secondary prevention, which include transit, trauma site care and triage, and then in-hospital transit care, and how the patients at trauma sites are referred for neurosurgical care. They can go to primary care or go to trauma or neurosurgery center. Next slide, please. Many of these have challenges in developing countries because of the logistic constraints. I don't want to keep beating about that drum. So in-hospital care is that of evaluation using the American Trauma Life Support Protocol to check for life-endangering problems in the airway, breathing, and circulation, and having stabilized patients when they are deemed to have traumatic brain injury. The next is to ask for imaging, brain scan, we can CT or MRI, and angiography as needed. That is the standard of care. Where, next slide, please. And then the total care continuum shows that we can also then think of tertiary care or prevention, depending on people's leaning, which can be physical rehabilitation, social, occupational. These are also not yet well understaffed and can only attend to patient needs just for a fraction of the time that's needed. Occupational therapy on its own is actually hardly known. And social rehabilitation, that's also formally not so well organized, but at least one good thing from African perspective is the extended family system of care, where you could expect patient relations to help take care of some of the reintegration of patient post-traumatic brain injury. So next slide, please, next slide. So delayed in-hospital presentation, reference to regional neurosurgical units sometimes that are far-flung from the main neurosurgical units is one of these well-known features of care of traumatic brain injury in Nigeria. Next slide, please. In our work, we show that usually there's this problem with timing of presentation of neurotrauma to neurosurgical center in the developing countries. And it has to do with the fact that many are from road traffic accidents, but because of the underdeveloped emergency medical system of care, where referrals are not well, referrals and in-hospital transit care are not so well organized, you get people presenting only less than 50% present within 12 hours of injury, and only about a third less than 4 hours. Many have been seen more than 4/5 from other primary care, which were delayed in 76/93 before they usually get to be seen in our units. So this delayed presentation can usually be caused by long distance travel to the neurosurgical center, the regional, or lack of funds. And they're usually brought in by family members and well-managed members of society. Next slide, please. So we have a less than optimum pre-neurosurgical care triage. There's occasional needless referrals of mild head injury. There's indiscriminate use of antibiotics, drugs, and some non-drug agents in the care of neurosurgery, traumatic brain injury in Nigeria. Next, please. But when they end up in the neurosurgeon unit, the neurosurgeon will assess, as I said earlier, clinically, and then ask for a brain CT scan. Now, the brain CT scan itself has issues of accessibility, though that's actually been improving in the recent past. In fact, I have a personal registry of head injury cases that I've seen in the last 10 years or so, that in the region of 1,400 cases. I can boast in that personal registry of more than 700 people who underwent CT brain, because I work in a teaching hospital in Nigeria where government subsidy allows the CT to be a little more affordable. But it is still a challenge in that an average CT brain costs some 36,000 naira or so, about $100 in Nigeria. And people who live on $2, less than $2 a day, as I said before, are expected to pay out of pocket for this imaging study when they are needed. Next, please. So again, when the brain image has been done and you then have decided to not need to operate a patient for non-operative care, there are issues with neurocritical care. You don't have a dedicated neurocritical ICU, intensive care unit that is. All you have is a hospital-wide multi-specialty intensive care unit where the neurosurgery team will be allocated some beds. As a rule, we actually overspend our time, overuse other people's beds in our units. They all have yell at us for taking all the beds there. And then there's also, and the affordability of the ICU is also something of a big concern. It's even more expensive than neurosurgery operative care, more expensive than CT brain, again, by people who are impoverished. Plus, there is no facilities for intracranial pressure monitoring. These are things that a person who takes care of brain injury in Nigeria has to contend with. Next slide, please. So, but when you do decide to do operation for a brain injury, it used to be that in this part of the world, in the absence of a CT brain, many earlier publications would suggest that borehole trepanation was something to do either exploratory or therapeutic, but that appears to be on its way out in even Nigeria now. Brain CT availability, increasing availability of brain CT with precise diagnosis of intracranial pathology makes that to be something of an extent. We now do craniotomy and decompressive craniotomy, though they are still these are very exorbitant surgical undertakings, but we have hospital arrangement for getting some of these things to be carried out, some of these surgical procedures to be carried out for the care of the life-threatening patient first, and then these can be settled later. Again, there are other logistic problems that go with that, but for now, that's what we do. Next slide, please. The surgical indications in the light of what we see by CT include what the rest of the world knows: extravascular masses, extradural hematoma, acute subdural hematoma, brain contusion, traumatic intracerebral hemorrhage, open depressed fracture, and so on and so forth. Next slide, please. What follows now are some of the images of the things we see in the care of the traumatic brain injury in Nigeria. This is a picture of an acute extradural hematoma in the patient. Next slide, please. Next will be an acute subdural hematoma with brain swelling, brain contusion, CT Rotterdam score 6. Next, and then an intracerebral hemorrhage, traumatic. Next slide, please. Next slide, please. Or tension hematocephalus. We've had cause to now take care of many of these now. No, previous slide, please. Previous slide. Previous slide, please. Yeah, we've had cause to take care of this kind of the presentation, traumatic tension hematocephalus with the Fuji sign, and then we transcranial surgical repair. Next slide now. Next slide, please. Or open depressed skull fracture. Here we see the kind of thing that. Next slide, please. So where there's no ICP monitoring, intracranial pressure monitoring, and the intracranial pathology is not a tension hematocephalus that is itself, that what you need to do is dictated, decompressive craniotomy features prominently in the neurooperative care of the head injured in our parts of the world, especially for the moderate and severe head injury, sometimes for mild head injury too, in the setting of focal deficits, seizure, neurological complaints, and CT findings of masses, contusion, misline shift, and basal assistance effacement. Next slide, please. So this decompressive craniotomy is sometimes preemptive in our units, in my practice, my personal practice. By the way, I practice in a university teaching hospital, like I said earlier, where we have 6-member faculty of neurosurgery. We actually have 4 of us are professors in the university, the other 2 are lecturers, young lecturers. So I, as a rule, deploy the decompressive craniotomy not as a third tier nor the last ditch effort, in that the non-medical means for me, non-surgical means, the medical, non-surgical means for me to mitigate possible risk intracranial pressure with no immediately evacuable surgical mass, intracranial mass, is a low-intensity medical measure for decreasing risk intracranial pressure. In just elevation of the head of bed, intravenous monitor. As a rule, we do not have hypertonic saline in our practice, and use of analgesic and anticonvulsant. For that reason, it's been our considered opinion that the decompressive craniotomy may need to be moved higher in the tier of the care of the traumatic brain injury. Next slide, please. So we will do the decompressive craniotomy for a case like this. At the initial phase of our practice, we will watch a person coming with a moderate head injury, Glasgow Coma score 12, and CT with brain swelling more to one side with midline shift, some brain edema, and we wanted to give a monitor head of bed elevation the usual. But down the line, they will just, right at before our very eyes, deteriorate and have continual systemic issues for which, in the times past when we weren't deploying the decompressive craniotomy as freely as we now do, you just come back the following morning or later and find the patient had perished. And it used to be such one of those sad moments for one's practice. But for those cases, we would do preemptive decompressive craniotomy. That's our experience. Next slide, please. Next slide, please. But for the well-defined cases that need the compressive craniotomy. This is an example of an acute subdural hematoma with all the bad features of malignant brain lesion. We will do the full blast decompressive craniotomy. Next slide, please. But our decompressive craniotomy will then, as a rule, be the inch decompressive craniotomy. We would rather do inch craniotomy or inch decompressive craniotomy. And our technique for that is what we term inch decompressive craniotomy temporalis. That is, we inch the bone flap on the native temporalis muscle, thereby making it less expensive for the patient to afford. Plus the fact that hinge craniotomy has that extra attraction for the developing countries like ours, where theoretically, and in majority of the cases, you do not need a follow-up cranioplasty. Cranioplasty surgery to make good the cranial defect from the traditional decompressive craniotomy. Plus, hinge decompressive craniotomy also obviates the need for the other surgical maneuvers and logistic issues that come with raising a free bone flap, needing to store it in some refrigerator somewhere or in another part of the patient's anatomy. So we have had cause to find that this inch decompressive craniotomy serves our purpose and seem to be practically affordable for our patient compared to what might have been. Next slide, please. So here I'm showing in a pre and post montage of images the acute subdural hematoma and all the bad signs we showed before, the midline shift, the total shutdown of basal system. Whereas post-op, 2 days post-op, we see things opening up again and intracranial anatomical symmetry being restored. And usually this kind of patient, they will go home in 2-3 weeks from in hospital. And in 2-3 months, they'll be back to their pre-trauma profession, state of well-being. Not only for the compressive craniotomy, we have actually had the same cause in the light of some other, light of the same concept of needing to look for low-cost solution to problems here. I've had cause to also make some other innovations in the care of the operative treatment for open depressed skull fracture, in the operative care for the mitigation of tension hemocephalus, as I said earlier. So in essence, next slide, please. Next slide, please. The traumatic brain injury and the neurosurgery in Nigeria is that of a practice in a challenging landscape regarding optical care. All of the things Dr. Shabani listed before regarding the roadmap from Peshawar. There were, in all those areas, in all those metrics, there are areas where there are still issues with our practice in Nigeria. But if one does not get too nihilistic with himself, if you still come knowing that necessity can be the mother of invention, we do have a mindful for gratifying low-cost innovations in the care of the head injured in much of Nigeria. Thank you very much for your attention. Next slide, please. Next. And I'll take questions and clarifications if there are. Thank you.
Thank you, Professor Adele, for the good presentation. Since we don't have the presentation from a doctor from Pakistani, we would like to invite comments, questions, additional points to the two presentations. The first presentation by Dr. Shabani and the second presentation by Professor Adele from Nigeria. You're welcome.
So I had a question for Dr. Shabani. We talked about it a bit earlier. Can he describe, we have now over 100 attendees in the region, you know, his career path in a way from neurosurgeon to a policymaker with the WHO and WFNS as hopefully an inspiration for lots of young attendees at the course.
Yeah, just to mention it briefly, you know, when you get into practice from school, number one, you are challenged, you know, first by the resources which are available at the hospital, the country, within the country, the cases, and the overwhelming enthusiasm of patients that now a savior has come to the country and to save their lives. That's experience which most of my colleagues will share with me. And then you find that you cannot do much. And then you realize that you have to go back to your mentors to get some more ideas. And in this way of shopping around, you can get collaborators like the way I got Weill Cornell University. Thank you, Professor Hato, Dr. Mangat. And you start collaboration programs because number one, you cannot convince policymakers anything without valid data. That's number one. So my main task has been with developing valid information for policymakers. And this is how I came up and we met President Jakaya Kikwete with the help of Professor Hato, his friend, and he accepted to see into what we are doing in Tanzania. And we have been supported that way, stepwise, to the extent that whatever we present in the meetings, in the journals, this is how people realize that someone is somewhere in this world. And I got invited with the WFNS Neurotrauma Committee. I'm the member there. And this is how we came up with the comprehensive policy protocol for the neurotrauma care in low and middle income countries. Not least to say, even the Cambridge University, I was invited there and still getting many friends. So this is how we can develop and make changes in this part of the world. Have I answered correctly?
Yes, thank you very much. I think your journey path is quite unique, as is a lot of senior faculty in the region. But I think since we have a lot of young people, it's good to hear firsthand experiences and to reiterate a footnote that Dr. Hartle's email always carries. If you want to go quickly, go alone. If you want to go far, go together.
Exactly, yes.
Thank you. Thank you very much.
Yes, any other question, another additional point or clarification?
If I'm,
sorry,
go ahead.
I'm sorry, I would have a question that's a little more technical. We had from Dr. Adelaide, he talked a lot about ICP monitoring and craniotomies and decompressive craniectomies. And maybe this is a question more for the case discussions or for later, but we had a presentation in New York by one of my colleagues who's done a lot of work on pupillary responses and the relationship to ICP. Is that something that you're using now in anywhere in East Africa or in Africa for as a means to assess patients in the ICU that would be less invasive, since ICP monitoring is not available?
Sorry, please. I don't get the question. Sorry. As in pupillary reaction post decompressive craniectomy as a means of measuring and following up?
I mean, instead of invasive ICP monitoring or in the ICU in general, do you have any way to assess pupillary responses and correlate that to the patient's neurological status and patients who are comatose, for example? I know this is a very technical question, but since we talked about ICP monitoring, I was just wondering about the concept of sometimes these technologies are much more advanced in areas like where you practice because of the whole concept of leapfrogging. So I was just wondering if you ever looked into that, because that's a very exciting area of research, and it may be a way to avoid invasive monitoring, which is very costly.
Yeah.
Well, beyond the usual bedside clinical examination of pupillary reaction to light. I'm not sure there's any other thing special that we do about the pupillary reaction to monitor patient in ICU. I know theoretically there's also the optic nerve sheath diameter measurement by ultrasound, which is some of the things that are also supposed to be low cost, non-invasive, being promoted. Unfortunately, we don't have that yet in Nigeria in my unit, but it's there. We're also looking at it as one of those low-hanging fruits things that we hope that with time we can also acquire. Thank you.
Thank you.
Yes, I hope we have no any more questions. So I would like to call upon Dr. Hoffman to take us through the cases for TBI for further discussion. Thank you, Professor Delay, so much. Thank you, Dr. Shabani, for the highlight on the Peshawar Declaration and our perspective on the low and middle income countries. Welcome, Dr. Hoffman.
Yeah, greetings everybody on the different time zones you are in. My duty today is quite simple. It's just to moderate on the case discussions which we have. We have a multiple case discussions, about 5 of them, which will be presented by different doctors. After that, we'll have a panelist of COSEXA on various countries, which is documented on the brochure. So our first presenter will be Dr. Mbwambo, who will give a highlight of a case discussion. But in between of this case discussion, we'll pose the questions which the answer should be yes or no. And you can answer it through the polling stations on the lower side of your Zoom, of your Zoom. What you see down there, you have to poll whether it's yes or no. And then later on, we can continue with that case. We would like to see the challenges, evidence we have of the different decisions which we have, especially in the resource scarce areas like ours. So Dr. Mbwambo, who is a neurosurgeon, who is working in a co-sister hospital in Dar es Salaam, will present the first case. Please welcome.
Thank you very much, Dr. Hoffman. I'm actually working at the new hospital, Loganzila. So I have a short case of a child, 8-year-old girl, who sustained a motor traffic crash nearly 4 months ago. She was going to school and then she was knocked by a bus. And she sustained multiple injuries. And these are the injuries that she sustained. At the day of admission, it was diagnosed to have a severe TBI. The admitting GCS was 7, but she was also found to have a skull fracture. With that also, she had a chest injury. There was contusion, mainly in the left lung and left hemothorax, which was subsequently treated by underwater seal drainage. But she also had a left humerus closed fracture, which was splintered, and left femur closed fracture, which was also splintered. And these were the initial CT scans on the day of admission. And as you can see, there is contusion on both frontal lobes, but you can also see that there's an obvious skull fracture in the left frontal bone. Here and here, and a bit of pneumocephalus, but you can clearly see how bad the left frontal bone was contused and the associated edema in both frontal left and right side. But what was very striking is the extent of fracture in the frontal bone, which involved the roof of the orbit, and there was extension actually of the brain matter into the orbit. Also, you can see here that this was a comminuted fracture involving the frontal bone, frontal air cells, and obviously pneumocephalus on this side, and there was associated edema of the brain. So the first of all question for this case is this a surgical case? Would you opt for surgery with regard to the associated injuries of the chest contusion, hemothorax, femur, and humeral fracture at the same time? Yes or no? before we proceed?
So you have 30 seconds. You can answer it on your poll down there on your screen, whether it's yes or no. And then we'll proceed after that. Okay. Proceed. Can proceed.
Okay. So this was the sagittal view. As you can see, the extent of the injury, both on the skull and the brain matter, and also the involvement of the roof of the orbit and the maxillary bone, and close to the nasal, and even the zygomatic bone. This was a pretty extensive bone injury. So in the ICU, the baby was intubated and received treatment in the ICU as per our Brain Trauma Foundation protocol. And fortunately, she remained stable throughout the ICU. After 3 weeks, we struggled with our ENT guys, and they were able to continue with the oxygenation through a tracheostomy. So this is nearly the second week, if I'm not mistaken. She developed this particular swelling in the left eye, in the left frontal region, as you can see. So this is another second poll question. What is the associated probable diagnosis going on in this patient? Again, we've also 30 seconds to add a diagnosis. Should I relaunch the first one? The second poll question is this: what is the new addition as far as the diagnosis is concerned because of the development of the swelling in the left eye?
Dr. Mbwango, the questions are just yes and no questions, but I was just wondering what the other, if you just go a couple slides back, I wonder how the other COSEXA panelists would have handled the case.
So should I end the polls? The polling? Talbot.
You can proceed.
So let me proceed, and then we will discuss later. So this is the same week, second week of surgery that we saw this development of the swelling. And this is a short video that showed that this swelling was quite compressible. You could reduce and you could be able to see the eye there. It's not playing. No problem. So this is the third month in the ICU. The baby actually survived, and she was subsequently extubated and continued to with the tracheostomy. And then we changed from nasogastric tube to orogastric tube, and the fractures were pretty stable at third month. But initially we thought that swelling was a growing skull fracture. But what we discovered is that there was slow decrease in the size of the swelling. And at this stage here, as you can see, the bone was very flat and the swelling in the eye has subsided except for this protruded mucosa of the superior eyelid. And then these are weeks later. As you can see, the eye has, the swelling in the eye has shrunk, and there was only a small depression in the area on the site of the fracture. So the challenges that we faced in this particular patient, that this was a polytrauma patient. And we thought probably we could have needed cranial plates or many plates to secure the fracture, especially the fracture fragment initially, but we had no any means of securing these gadgets. So we opted to treat the suspected groin skull fracture conservatively. Unfortunately, the swelling was stable throughout the stay of the baby in the ICU, and we discovered that the swelling was actually decreasing with time. So this was the first month in the ward. She was transferred to the ward, and at this stage, we were able to feed the baby orally. In the ICU, she developed pressure sores, as you can also see here in this left eye. But this also healed progressively, and at the same month she was discharged home. So, so I thought with these points here that we might have been dealing with a groin skull fracture in the very first place, and these are the terminology that are normally used when you have such scenario. Though in this case, we thought it was too early for this particular baby to have developed the groin skull fracture. But I thought it was necessary for us to look at this also and see if at all we were dealing with a groin skull fracture or not. So these are the terminologies used in a groin skull fracture. I think I still have time. It occurs in 1% of linear skull fractures, and 90% of patients are below the age of 3, and the 50% are below the age of 1 year, but it also rarely occurs above the age of 3. It commonly involves the calvaria bones and commonly the parietal bone. Orbital roof and occipital bones are rarely involved. The issue with the groin skull fracture is that the pathology is not clearly known, but there are important factors, development of groin skull fracture, and these includes dural tear, entrapment of arachnoid membrane, and the presence of brain tissue within the fracture margin. And for a child or an infant to develop groin skull fracture, these are the 4 important observations: that there has to be a skull fracture in infancy or early childhood, dural tear at the time of fracture, brain injury underlying the fracture, and increase the size of the cranial defect. So for it to occur early in childhood, normally because of rapid growth of the brain and the skull, and the dural matter normally at early age is tightly bound to the skull. So when there's any fracture, it involves the dura also. So mechanism, as I said, is dural disruption and outward driving force from within the skull. These are the 2 things that will cause a groin skull fracture, as seen in this particular case. As you can see in this case, that there is a fracture, and then there's a edema, which is the driving force in that manner. And if there's any associated things like diffuse brain injury, as seen here, or hydrocephalus, or if there's any specific lesion like hematoma, all those can contribute to development of groin skull fracture. So if the dura is repaired and the outward driving force are diminished, then this can lead to subsequent healing of the groin skull fracture. So surgery is the same in the same manner: repair of the dura and reconstruction of the skull, and this is cranioplasty. A delay could result in more brain damage if treatment is delayed. So the goals are these: to identify the dura defect and repair it. If there's an associated cyst, to do athesiolysis and cyst decompression, and an watertight dura closure. And then for the skull is to do definitive cranioplasty. Duroplasty again is the same. And the skull reconstruction can also be used by using autologous split calvario bone. Or there are several options like silicone prosthesis, titanium implants, artificial bones, or polyethylene material. Otherwise, thank you very much.
Yes. Thank you very much, Dr. Mbambo. So we have a COSEXA panelist. We have COSEXA panelists who are supposed to join us on this meeting. From Uganda, I think we have an apology from Doctor from Uganda. COSEXA is a College of Surgeons of East, Central, and Southern Africa, which actually is also endorsing this course, including to other organizations. But I have seen from Ethiopia, we have Dr. Laeke from Ethiopia. I've seen you have logged in. Can you kindly share with us your experience on this matter, on this case?
Yeah.
Dr. Laeke.
Yeah, thank you very much. I'm working in a public hospital, so in Black Lion Hospital. So as you nicely presented, this is a complicated case, and it's a difficult case to manage in our setup, especially given the age of the patient. So this patient is a polytrauma patient. When we look at the head injury on this patient, the patient has a complex basal frontal skull fracture, which goes into the frontal sinus, which involved both the frontal sinus and massive frontal contusion. So given the setup and the ICU setup, given the head injury, I think the patient has an indication to be operated. But as we saw from the patient's treatment course, she has a nice improvement, and the challenges in the ICU is managing this patient with all polytrauma and intubation, and also tracheostomy care with the rehabilitation. But for the complex skull vault fracture, we do craniotomy, bicoronal craniotomy, and we debride the contused brain, and also evacuate the ICH, and also strict dural repair will be done, and it's been in our hospital. Yeah.
Yeah, thank you very much, Dr. from Tikur and Bassa Hospital. I think if I remember properly, the Black Lion. But also we have panelist, Dr. Ignatius Essiene from Cameroon. Can you, if you're available, can you kindly share with us your experience on this case? Dr. Essiene.
Sorry, Dr. Essiene is not there, but Alex from Uganda is there.
Oh, okay, thank you very much. Can we have experience from Dr. Alex Muhindo from College of Surgeons of East, Central, and Southern Africa, currently working in Uganda? Dr. Alex? Okay, we have also Sylvia Shisama from Kenya. If she's online, kindly share with us your experience. I think no one is around. Professor Roger Hatto, you have seen the case. Can you also share with us your experience? How will you do it better in a well-resourced country where you are in a case like this? And what are the learning paths we can have from this case?
Actually,
Yes,
I wonder if you would like me to contribute before Professor Atru from well-resourced talk. I'm from a low-resource place like you.
Thank you.
Yeah, I'm asking, am I allowed, or I should?
I think you're allowed. As a senior surgeon of a similar state, you're allowed. You can proceed.
Oh, thank you very much. I don't know what to tell you, my colleagues. That was a difficult case you had there. anywhere in the world, whether in Weill College, whether in Tanzania, whether in Nigeria. You have the two frontal lobes burst, bilateral burst lobes. Question is, I wonder whether that's one of those medical cases occasionally that make you wonder, should I not? If you do, you don't get much reward, yet you can't bring yourself to saying, do not resuscitate. So you let the person be. So I'm wondering about the cognitive development of this person after surgery and the kind of rehabilitation they can get. That's one. Next also is that as for growing skull fracture, part of the presentation that you made, I'm not sure about that, the fact that could be indeed a growing skull fracture. The theoretical underpinnings that you showed were correct. But again, diseases don't know textbooks, right? But the classic growing skull fracture is a linear skull fracture, sometimes hardly perceptible, if you like, but that had unknown, unappreciated underlying dural tear, meningeal tear, and brain injury that then over time expands. That's what you then say is growing. But that fracture you had was already a big fracture. At the beginning, it was a comminuted frontofacial fracture with some of the bone elevated and all that. I don't know how that you could then down the line say, if you see a bony defect there, that was a growing skull fracture. That's the problem. However, but the theoretical basis you established for growing skull fracture, those were correct, as I know. Thank you.
Thank you very much, Professor Amos. I agree with you. That's why it has to, if it's a growing skull fracture, you expect it to keep on growing and not to reduce to a normal, to a normal size. So possibly that was an edema, surrounding edema, which was there. Professor Roger Hatto, your comment on this case before I invite the second presenter.
Yeah, listen, I apologize. I got a phone call from the hospital. I had to log out, so I didn't follow the whole case. I apologize. I wasn't online until I just called. But it sounded like a very complex case.
Yeah, Dr. Halinda Mangati, do you have any comment on this one?
I'm just curious. So in terms of two things, in terms of trauma resuscitation, what was done before, chest tubes for hemothoraces or taken to operating room for neurosurgery, number one. Number two is, what was the outcome? Because I imagine you could not rely on pupillary reactivity on the worst side because the systems were closed. There was distortion of the brainstem, and I would imagine bilateral pupils are affected, but one pupil you just, because the damage you would never see. So I'm just curious what about the two things in terms of resuscitation and what the outcome was for the patient.
Yeah, the normally at our center, the resuscitation, the initial resuscitation is done at the emergency department. And when they have discovered that the patient has any neurological injury, that's when we are consulted. So we were consulted as second team. Okay. Of course, with other teams from orthopedics, from ophthalmology and maxillofacial, but everybody was a bit concerned about the condition of the patient, and then they left the patient to us, neurosurgery. They said unless the brain is better, they can't start with the fractures or start with the eye. So initial resuscitation was done at the emergency department, and the patient was found to have hemoglobin of 6 and received subsequent transfusions to a stable level. The outcome was not very good in terms of cognitive function. This child could not do anything at the time we were discharging her home. But she was awake. She had some episodes of emotions. She used to cry, but she could not even stretch herself or do anything, even unable to. She was also unable to walk. But we saw her on subsequent visits. She was a bit healthy, but cognitive functions and ability to care for herself were very low.
Yeah, well, I have to commend you. That's given her initial condition, that outcome I think is actually quite remarkable.
Yeah, I agree.
Thank you very much, Dr. Mbwambo. That's quite a good case, quite complicating, and the decision-making on how to go through. Our second presenter is Dr. Silvio Mwesiga. He's a registrar at Neurosurgical Unit at Muhumbili Orthopaedic Institute in Dar es Salaam, Tanzania. We will present a complex case on severe traumatic brain injury, decision-making. Again, I would like to remind you, at the mid of the presentations, we'll pose quite simple questions, which you have to answer through your poll on your screen, whether it's yes or no. Dr. Mwesiga, can you proceed?
Thank you, Dr. Othman. Hi, everyone. Let's now move to the second case. Let's move to the second case. This is the severe TBI case. We have had, this is the 25-year-old male who presented to hospital about 10 hours post-trauma in a road traffic crash. On arrival, the GCS of the patient had a motor score of 4, I1, was intubated. So we had to do resuscitation at the emergency unit. And this is the initial CT brain, which showed right subdural collection, as you can appreciate on the slides. Now, this is the CT brain, which showed hyperdense subdural collection on the right side with the midline shift. Now, considering the volume of the hematoma, borderline volume of the hematoma, as well as status of the ventricles, we had to make a decision. Now, the poll question you can ask at the moment is, in this case, for surgery or for non-surgery?
Hey, it's Dr. Hartle. It's Roger. Can you just tell us real quick, what about the pupils? And it seems like vital signs are stable. What about pupils?
The pupils were 3 millimeters both sides reacting to light.
And can I make a comment here too, or I should wait? Adele from Nigeria. Am I permitted to make a comment here now, or should we wait till later? Since I saw Dr. also make comments.
No, Professor Amos, you should wait. Actually, Professor Roger needed the clarifications on the pupil. If you look at this picture, okay, there is a minimum midline shift. If you look at the ventricle, ipsilateral ventricle is not effaced, and the contralateral ventricle is not dilated. So will you proceed for surgical intervention or for conservative therapy? It's a polling question, whether yes or no. Yes, surgery, yes or no.
Thank you. Now, on our settings, the option was to do surgery, and the surgical plan was to do craniotomy for evacuation of the subdural hematoma. Despite of doing craniotomy for subdural hematoma evacuation, the patient post-op was admitted in ICU, and we had a number of complications post-op. One of them is the patient wasn't intubated immediately, so the patient developed surgical site infection that led to ventriculitis and hydrocephalus. On the left side, you can see the immediate post-op imaging that shows the effacement of the ipsilateral ventricle, as well as herniation of the brain through the surgical window. On your right side, you can also appreciate the control CT brain that was done 25 days later. You can see significant ballooning of the ventricles, persistent herniation of the brain tissue through the surgical site. Basing on this follow-up imaging, we had to do CSF diversion with an EVD that was inserted immediately. On the analysis of the CSF, we were able to grow Pseudomonas that was sensitive to ciprofloxacin. So the patient was kept on antibiotics as well as other supportive medication.
Thank you, Dr. Mwesiga. So we need to have comments from the COSEXA panelist. Dr. Sylvia, I think you're around. Can you kindly comment on this case? The College of Surgeons of East, Central and Southern Africa, who are endorsing this cause, as well as our OSPI and FIENS, NAS foundations of international education neurosurgery. Dr. Sylvia? Dr. Beverly, can you comment on this?
Yes, it's Dr. Shitsama. Thank you. That was a very interesting case. Looking at the GCS of the patient at the time of admission, I would operate the patient, considering the setup that we have. That if I'm to consider follow-up observing and looking at the vital signs, I might not have the window of opportunity. I would consider surgery. And the challenges you experience are challenges we also face in terms of infection, especially post decompressive craniotomy, and also how he recovered throughout the surgery.
Thank you, Dr. Jesereni. Do we have another comment? Professor Amos Adele from Nigeria.
Thank you.
Now, yes.
Thank you. Yeah. If you can please show the slide of the acute subhematoma. If you please show the slide of the acute subhematoma. Yeah, because when you were discussing this, the point was made as suggestive that the reason for the surgery was the volume of the hematoma. And I was going to say, no, the volume of hematoma we're looking at here will not on its own be enough to operate this person. In fact, if you could, by some magic, reverse some of the brain swelling I'm looking at, I had the man have only these subhematoma, that will not be the indication for surgery. The indication is that, as is classically said, unlike acute extradural hematoma, which is just a bleeding vessel somewhere collecting blood and causing respiratory pressure, the volume of the hematoma is the issue there. But as for the classic acute subdural hematoma, it's not that blood film you're looking at. It is the associated brain injury, which is what you see a bit of here, as in this brain swelling and some midline shift. Of course, I imagine the Dr. Arturs and people in those kind of environments might sometimes consider ICP monitoring and all that here to clarify whether they should proceed to surgery or wait. But for me, in a developing country like you, this is a case for decompressive cranectomy, which will then dictate what you do as surgery. If you just operate because you want to evacuate the hematoma, because you are imagining that the hematoma is the cause of the problem, then you can make, if you like, a mini bone window, and that's be enough. But if you go telling yourself that you are going for a decompressive cranectomy here, then you might then consider the benchmark for decompressive cranectomy, a bone flap that's at least 12 to 14 centimeters wide, and all the other things. Then you then know that you are going for decompressive cranectomy because of the structural images suggestive of raising the cranial pressure here, not just about the acute subdural. That's the way I like to look at this. Thank you.
Thank you very much, Professor Amos. Dr. Laeke from Ethiopia, a panelist, are you around?
Yeah, thank you very much. It's an interesting case. I would also operate on this case given the volume of the hematoma and also a diffuse brain swelling that's visible on the brain CT. So we usually prepare this kind of patients for decompressive craniectomy with adequate bone removal. But to do craniectomy, we sometimes decide intraoperatively to put the bone floating in the brain. it depends on the to what extent the brain is swelling in intraoperatively. So that's one option, like to do decompressive craniectomy, and also to take into consideration to do floating decompressive craniotomy on this kind of patients. Sometimes the acute subdural hematoma might be associated with intracranial, intracerebral hemorrhage and so on. So especially for those kind of cases, we might usually do a decompressive craniotomy with floating bone on top of the brain and duroplasty, a generous duroplasty.
Thank you, Dr. Laeke from Ethiopia. But if you look at the post-operative pictures, these patients developed hydrocephalus, and it was decided to insert a VP shunt intraventricular catheter on the left side because of worry of surgical site infections on the right side. But if you look at the pictures projected there, if you look on the right side, you see still we have a ventriculomegaly. Can you share with us the experience on that and how to go through, Dr. Laeke?
Yeah. So as you said, there is a risk of having ventriculitis in this kind of patients, but we also take into consideration doing a ventricular drain on the occipital horn, on the lateral ventricle, on the occipital horn, because as on this picture, the EVD is draining only on the left side of the lateral ventricle. So if the ventricle keeps on dilating, I think one of the options is to do ventriculostomy, another ventriculostomy on the right side.
Okay, thank you very much, Dr. Laeke. Beverly, can you invite one person on behalf of those panelists who are not available to comment on this case so that we can move to another case?
Okay, but before I do that, I'd just like to ask a question to the MOI team. Pseudomonas is very unusual. Why do we think the patient had pseudomonas? And then in response, Claire Karikezi, who's also in the panel from Rwanda, perhaps could tell us about her experience with cases like this.
Dr. Shabani, you want to? Okay, Claire, okay.
Hey, it's Roger Hartle. Can I make a comment or a question?
Yeah, you can comment, Dr. Hartle.
Hey, I was just so the goal this patient clearly would have undergone like urgent or emergency surgery here, with a very generous craniectomy and evacuation. With that GCS and those findings on the CT scan, we would have taken them to the OR emergently. If you go back to the, I just want to point out, I don't know if the goal was to do a decompressive craniectomy. I guess it was here, right? In terms of a technical detail, if you look at the coronal images, if you look at the CT scan there, for decompressive craniectomy, really to afford generous decompression, you want to go down in the temporal fossa. You don't want that bone sticking up on the right side there. If you see on the coronal reconstruction, so that's a crucial part in terms of the technical details of performing a decompressive craniectomy. You got to go down into the temporal fossa and remove all that bone. Just a technical comment,
Professor Roger Hartle, if you look at the first picture, the goal was doing craniotomy and evacuations of acute subdural hematoma. But intraoperatively, we found there is a massive brain swelling and herniation, and it was decided not to return the bone flap. But I agree with you, for the better and good decompressive cranectomy, you need to release or to involve all the frontal, parietal, temporal, as well as occipital. Should be a large craniotomy on one side. Thank you very much.
So Claire is able to respond.
Yes? Claire, okay.
Hey, hi everyone. Thanks for having me. Can you hear me?
Yes, we can.
Yeah, so this is a 25 years old male who presents with an acute subdural hematoma. So there's no question that he needs surgery. And I go with Professor Hartel, what he just said, because I was looking at that coronal image. That subtemporal craniectomy wasn't generous enough. And I think the removed bone was a little bit small. And that's why you had herniation of the brain. So maybe you will have gone for a larger craniotomy. So that was my comment.
Thank you, Claire. So thank you, everyone. Thank you, the panelists. So right now, I'll invite a third case, which will be presented again by our registrar, Dr. Juliet. He's a young registrar who is working at the neurosurgical unit here in Dar es Salaam. We'll present a third case on severe traumatic brain injury in a patient who is pregnant. Kindly, Dr. Juliet, you're welcome.
Hello, I'd like to take you through the third case, which is a TBI case in pregnancy. So this is the case that we attended here. It's an adult female, approximately 30 years of age. So she came as an unknown patient. She was found lying on the road with no idea what has happened to the patient. She was pregnant, approximately 28 weeks by ultrasound, suspected to have been involved, to have sustained injury to the head. She had signs of injury externally. So upon examination of this patient, she had a Glasgow Coma score of I4, M5, V2. The pupils were bilaterally equal-reactive to light. She had stable vitals, and she had no any weakness, and the fetal heart sounds were heard, and they were normal. So she came with this brain scan, which showed a left acute subdural hematoma with underlying left temporal parietal fracture with coronal structure diastasis, as it is shown on the image. So this patient was prepared and underwent craniotomy for hematoma evacuation. And post-op, the patient improved very well. Her GCS day 1 post-op was I4, M6, V4. So before we continue with the discussion part, I'd like to pose a question. So you attend this patient at the emergency department with the GCS of 11 out of 15 stable vitals. Will you opt to intubate the patient at the emergency or wait until you get to the OR?
Okay. Thank you for voting. You can proceed, Dr. Juliet.
Okay, so our main point of discussion will be ICP management in pregnancy. I'd like to welcome the COSEXA panelists to lead on this discussion.
So I call again for panelists, College of Surgeons of East, Central, and Southern Africa, COSEXA panelist, Dr. Sylvia Shisama. I know you're around, we've seen you logged in. Can you kindly comment on this case, Dr. Sylvia?
Thank you, Dr. When we consider pregnant women, you're considering the life of mother first, but this is a woman who was 28 weeks pregnant. So some studies that have been done, there's judicious use in terms of ICP management. There's judicious use of mannitol at lower doses, but these are very individual cases. But you're also worried of fetal hyperosmolality as regards to use of mannitol and also reduced fetal lung fluid production. So head elevation is also useful in terms of ICP management in this children, in this mother, sorry. And you have to look at if the fetus is stable, you're worried. The first instance is to take care of the mother, and you have the obstetric team to look up after the child Thank you.
Thank you, Dr. Sylvia. Also, we need to, can we have comment from Dr. Jake Timoth from UK? Dr. Jake?
We're just unmuting him. Just give us a moment.
Okay, so while we're waiting, please, let's receive a comment from Ethiopia, Tikur and Bassa Hospital, Black Lion Hospital. Dr. Leke, can you kindly comment?
Yeah. I share the previous discussion. So this is a patient. This is a pregnant lady. So it might be difficult to manage the ICP. So I would rush this patient to surgery. But if she is deteriorating and if we are delaying the surgery for many reasons, we can give her a mannitol.
Thank you.
Hello, I'm Jake Timothy from the UK. Been listening very patiently and hearing all the different answers. I'm going to be slightly controversial and say that I probably wouldn't operate on her. I think there's a risk, obviously, to the fetus. I'd try to monitor her. She's got a motor of 5, so potentially you can actually clinically observe her and see what happens. And then if she deteriorates, then I'd probably consider surgery. That's my view.
I think that's supported by the guidelines. As long as we can monitor these patients, but probably with an ICP monitor or at least close neurological examination in the ICU, you may be able to watch that.
So I think that this is really challenging depending on your setting, because it would presume the ability for a continuous obstetric related monitoring in terms of CTG for the baby, and also the ability to have a comprehensive neurocritical care. Dr. Timothy, I'll just come back to you again, because you worked in different settings that are non-UK. Would the setting of the patient change your management?
Sorry, Beverly, just say that again.
I was saying that the resources needed to monitor a pregnant woman would include appropriate, CTG monitoring with obstetrics, as well as an appropriately staffed neurocritical care and access to theatre. As you've worked in different settings outside of the UK, would the setting that the patient presents in change your management?
I just wonder whether you can actually monitor clinically. Would that be possible? Of course, there's a risk of raising cranial pressure, but if you can monitor clinically, I think that'd be the best for her and the fetus.
Thank you, Beverly. Thank you, Jake. The point of learning here is that the life of mother should be taken priority first before the baby, but also nobody mentioned about the CT scan on a pregnant lady, whether she decided to do an MRI or not if you have all of them. But all in all, thank you very much, panelists. Thank you very much, participant. But now I call upon the 4th case presenter. Yes,
sorry,
Dr. Mangat.
I just want to make a quick point that I think we're focusing a lot on the medical surgical management in this patient. I think what is not to be forgotten of extremely paramount importance is discussion of this management with the patient. We don't know how precious the baby is, and that does alter the patient's preference. If this is a precious baby after 10 years and it's the first baby, they may choose a very conservative management, especially as Tim pointed out, she's M5. And if this is a 7th child, that does alter to a certain extent the risk-taking for the fetus. And then, of course, the possibility, the surrounding, can you deliver a 28-week-old child to a neonatal unit, or do you offer the patient that with radiation, even though it's 3rd trimester, we expect no deformity, but there is a small possibility. A lot of that discussions are incredibly important, I think, than just addressing sort of the subdural hematoma.
Thank you. Yeah, thank you very much, Dr. Mangati. I think that's an incredible comment on holistic approach on taking care of this case and decision-making holistically, but also you should take care of what you have around. Delivering at the 28th weeks and the chance of survival in our setting is quite very low. We have a high mortality at 28th week for that premature babies. So thank you very much, everybody, and for COSEXA panelists and all who commented on that. But I call upon the fourth presenter. And thank you very much, Dr. Juliet. It was quite a good presentation and a well-chosen case. Dr. Elizabeth, she's our registrar, one of our elite registrars. We are looking to become a neurosurgeon soon. We'll present a fourth case on expanding hematomas. Dr. Elizabeth, you're welcome.
Thank you, Dr. Othman. Hi, everyone. I'm Dr. Elizabeth, and I'll be taking you through the fourth case. So I'll be taking you through an 18-year-old male who presented at our facility 10 hours post-injury with history of being involved in a motor truck crash. So on arrival, his GCS was I4M6V5 with pupils normal bilateral reacting to light, with the chief complaint of headache with no any neurological deficit and no lateralizing signs. So we did a brain CT scan, which showed the left temporal acute epidural hematoma. And based on the CT scan findings, the hematoma was less than 30 cc. There was no significant midline shifts and no signs of raised ICP based on the CT scan. So I'll be posing a question and you can pull it out, and if you would have operated on this patient or decided on non-surgical conservative management. So that's question number one.
Thank you very much for pulling out. Dr. Elizabeth, can you proceed?
Okay, so at our facility, the consensus was to go for non-surgical conservative management. So the patient was admitted in the ward for neuro observation with anticonvulsant and pain to redo brain CT scan within 48 hours. But unfortunately, the patient missed the window for control brain CT scan within 48 hours because of financial constraints. But since the patient was neurologically stable, was discharged home on day 5 to be seen again at the outpatient clinic. So 3 weeks later, was seen at the outpatient clinic, still with persistent headache with a non-neurological deficit and clinically stable, but came with a control brain CT scan, which you'll be looking at on your screens. So from the control brain CT scan, now you see that the hematoma has expanded when previously it only involved the temporal lobe. Now we are looking at it from the temporal parietal occipital side with the midline, significant midline shift of more than 0.5 and effacement of the ventricles on the left side. So now question of interest is, would you operate on this patient now or still conserve the patient?
The second polling question. Is it for surgery or no surgery? So if surgery, say yes. If no surgery, write no.
Okay, so at our facility, the consensus was to do surgery, and craniotomy for hematoma evacuation was done. And post-operative patient fared well and was discharged home fully conscious with no neurological deficit. So point of discussion on this particular patient was a follow-up on conserved non-surgical patients, and also the role of radiological markers on predicting either the worsening or expansion of the hematoma, and the role of infrascanners on detecting early expansion of the hematoma. So I would like to invite the COSEXA panels to discuss this particular case.
I'd like to invite COSEXA panelists first, Dr. Sylvia, also Dr. from Ethiopia, as well as we have Dr. Ngerageza. So we should start with Dr. Sylvia.
Thank you. Looking at the history of an 18-year-old, first I note he had significant brain atrophy. I don't know if that's related to something he's consuming, but the fact that he had headaches, even though he didn't have any deficits, and the headaches persisted, and then the need of the repeat scan, and the clot expanded, and even looking at the image, you can see the different mixed densities, and that's one of the radiological markers that have been shown to be an indicator of probable expansion of the clot. So this is a patient I would consider surgery when I meet him at this 3 weeks post with the persistent headaches.
Okay, thank you, doctor. So the brain atrophy you see in this particular patient is because this patient is actually non-epilepsy on treatment. So he has some mild form of cerebral palsy.
Thank you.
Thank you, Dr. Sylvia. Thank you very much for noting the cerebral atrophy. Doctor from Ethiopia, Tikur and Basat, Dr. Leke.
Yes, the mixed density on the first CT scan warns us that the patient might have an expansion of his hematoma, but on the first CT scan, we will usually follow him up, but the second CT, the control CT scan, has a clear indication to be operated.
Thank you very much. Dr. Ngerageza Jafet, are you around? Dr. Jafet Ngerageza? Okay. Dr. Kenneth from Malawi, can you respond to this? Are you around also? Dr. Kenneth? Dr. Kenneth Mwenda.
Hello?
Yes, Dr. Kenneth.
Ngerageza.
Dr. Jafet. Karibu, Ngerageza, you're welcome.
I may not differ from the previous speakers. The reason for surgery could have been indicated by the follow-up CT that showed expansion of the hematoma. And however, one of the reasons the changes could have been brought by the changes, depending on the duration of from time of injury, could be active bleeding, but then could be the changes, the hemolysis of blood products following with the prolongation of time after trauma.
Thank you, Dr. Ngerageza. But also we have Dr. Weill Copeland from Tenwick, UK. Are you around? Can you comment on this case regarding the resource and the kind of environment which you are in? Dr. Weill Copeland?
Yes, I'm here.
Yes. Let's share with us your experience.
Sure. I'm currently practicing at Tenwick Hospital in Kenya. Frankly, I don't think I have a whole lot to add to the discussion already. I agree with the non-operative management based on the initial CT scan, but certainly think the follow-up 3 weeks later would be an indication for surgery.
Oh, thank you very much. So, finalists, we have a last case which I think we should listen to it. We have a little time, so our last case will be presented by our registrar again, and it's on controversial in neurosurgery. Dr. Albert, one of our elite registrar we have, a neurosurgeon to be in some few years to come.
Our last case today, we'll be dealing with controversies in neurosurgery. So it's a short case. It's a 24-year-old male who presented to us 10 hours post-trauma, motor traffic crash, presented with alpha level of consciousness. Pupils were bilaterally active to light and no weakness. But the CT scan which he came with showed contusions on the right frontal and a canter-coup injury on the left parietal lobe. So we see these cases very often, and the polling question for this would be, how would you go ahead and manage this patient? Would you go ahead and do surgery in the context of no ICP monitors, or will you conserve this patient and monitor clinically while this patient is in the ward for any kind of deterioration? So it's no surgery or no surgery, keeping in mind that you don't have ICP monitors, you only can manage this patient and observe clinically.
Sorry, just a clarification. When you say surgery, what exact surgery do you?
So, yeah, thank you. For this case, we would be worrying about expansion of the intracranial hematoma, increasing the ICP of the patient, because at the time of admission, we don't know exactly the intracranial pressure of this patient. So we can only monitor these changes clinically for this patient while the patient is in the ward, either any kind of neurological deterioration, any new symptoms such as vomiting or seizures. So in the context of no ICP monitor, would you go for surgery or just monitor clinically while the patient is in the ward?
Hey, can you tell us the pupils again?
The pupils were bilaterally equally active to light, 3 millimeters, both very active. He came with outer level of consciousness, and this is the glaucoma score which was admitted with I4M5V2.
And how often can you get CAT scans in these patients?
We don't have CAT scans.
Well, you got one there. I mean, he came in with one.
A CT scan we have, yes. So we can have on a regular, depending on the need, we can have a CT scan about after every 48 hours. We usually admit our patients and do a control CT scan every 48 hours to see any changes in deterioration or expansion of the hematomas.
The CT scan is in-house. Usually we can have a CT scan as long as the patient is within the hospital premises.
Yeah, it's a great case to discuss.
Yeah. So panelists, I should start with COSEX panelists available. I've seen 2 of them. We should start from Kenya, Dr. Sylvia. If you're around. Yes.
So traumatic intracerebral hematomas is a very controversial topic, but looking at the availability of, would I be able to get a CT scan as soon as I want in terms of observing him? Would I have a comprehensive ICU care for him? I would do surgery for the hematoma. Looking at a review that was done by Barbara Gregson on surgical decision-making in brain hemorrhage, they look at it in terms of patients with GCS of between 10 to 13, would benefit from surgery, and also a large intracerebral hematoma. However, they were not very clear onto the size. Looking at the intracerebral hematoma we are seeing in the frontal region, I would recommend surgery.
Thank you, Dr. Sylvia. From Ethiopia, Dr. Laeke, panelist.
Yeah, thank you. We used to have this kind of cases, and we used to conservatively manage, especially those patients who had a very good GCS. But in the wards, this kind of patients tend to deteriorate acutely with a very low GCS 3 to 4. So the monitoring was really difficult. So we decided to operate these patients as soon as they are admitted. So nowadays we are operating all patients, and we prepare these patients for a frontal decompressive craniectomy. and also evacuation of the ICH. Depending on the intraoperative finding, we decide whether to do a decompressive craniectomy or not.
Thank you. Thank you very much for your comment. I've seen also Dr. Abednego Kinasha is logged in. Are you around to share with us your experience? Dr. Kinasha is our teacher from almost all of us and the one who established the department in our center. Dr. Kinasha? Okay, we have about 3 minutes, so I can give 1 minute to Professor Roger Hatto to finalize on this case. If you have any comment on this.
Yeah, you know, it's a really challenging situation. I think if you have frequent CT scanning available, and if it's easy to get the patient from the ICU and safe to the CT scanner, then I think it may be reasonable to monitor and treat this patient non-operatively in the absence of ICP monitoring. But it really depends on the situation that you have available, and then I know there's some financial implications of getting CT scans for patients that may not be easy either. So I think that if you don't have that available, I think what the surgical plan is outlined sounds like a reasonable plan, and that would be another option. But this is like the Randy Chestnut kind of situation where you don't have ICP monitoring, but you need frequent CT scanning then.
Thank you very much, Professor Hatto. So I can conclude. Yes.
Can I make? I take off from. Hello, I take up from Professor Hatto. So you don't have ICP monitor, you don't have frequent CT monitoring and CT imaging. Actually, even if you did have frequent CT imaging, one other problem you will encounter is, should you have cause to decide either by clinical deterioration or CT imaging worsening that the patient should need surgery, if that should happen in some unholy hours of the night at 2 a.m. or 3 a.m., access to the operating room at that time might be a difficult thing in our parts of the world. So your best bet is at that first shot. First time, take your first shot, operate this patient. Thank you.
Thank you, Professor.
Which side do you do what about the left parietal contusion? I mean, so this patient's going to end up with bilateral craniectomies, isn't it? Because that parietal, it's a parieto-temporal, and it's going reasonably, it's not terrible, it's not a temporopolar, but you could expect that to expand. So you open up the right front, and you can expect the left parieto-temporal to also enlarge. And the cisterns look like they're nearly closed. So then do you do two at the same time? Do you do one and then do you do another one? Or I think it's a very tricky situation.
Professor Delay, on the early surgery, which can you choose?
Yeah, thank you. That was a tricky question the Dr. Mangat asked. Of course, when you face this kind of situation, you then have to take an intraoperative decision. What I will first do here, again, you don't have limitless access to the theater, and when you're also in the operative room, you cannot just be there forever. You just have to get the most done in the quickest possible time. So I would do a right-sided large frontal temporal parietal decompressive craniectomy procedure, evacuate that right frontal intracerebral bleed. That usually will be enough to give room for whatever little expansion or whatever that was going to happen from that left side lesion to kind of be accommodated.
So you'll be doing on the right.
But of course, yeah, I'll do it on the right. First, it is non-dominant side. Next, that's where the most hematoma volume is. Plus, I'll open up the whole cranium and decompress the cranial space with my decompressed craniectomy. So I'm not operating this patient as just simply hematoma evacuation. I'm going to be doing a decompressive craniectomy procedure. Of course, there's no doubt that there's the risk of that left-sided lesion expanding. But what can I do? That's what I have for now. That's what I will do, and follow up patients clinically.
Thank you very much, Professor. If you decide to treat conservative, what about the use of tranexamic acid? My last question. What do you say? What's your experience on this case like this? Is there any place for tranexamic acid injection in TBI if one could decide to manage conservative? Dr. Mangati?
So the CRASH-3 trial was just published, and 12,000 patients, and the confidence intervals went from 1.0 to 1.04. But when you look at the time slope, and what is good about CRASH trial is that it includes a lot of patients from low middle income countries, is that the time window is 3 hours only. So I'm afraid that tranexamic acid doesn't have a lot of applicability in middle income countries. There's just a systematic review published, including 8 studies that shows there is death or disability benefit of tranexamic acid in TBI.
Thank you very much, Dr. Mangati. I think we have learned a lot from this case on the holistic approach, challenges based, not only what we see from the CT scan, but also we should look at the patient status, resource available, as well as some other comorbid conditions. So thank you very much to the panelists from COSEXA region, as well as others for participating in this part. So I call upon next part where we'll discuss on the quality, how do you do it? The first moderator will be Dr. Jafet Ngerageza from Tanzania, as well as Zarina Shabai from Tanzania. Dr. Ngerageza and Zarina, kindly welcome to moderate this session. Thank you very much, everybody. And thank you very much, presenters.
Thank you very much, Dr. Othman, and all participants for the previous session. This session is being moderated by me, Dr. Ngerageza, and my colleague, Dr. Zarina. May I take this opportunity to invite Dr. Zarina to introduce the first presenter, the first presenter, and then we shall proceed from there. Karibu, Dr. Zarina.
Thank you very much. Good afternoon and good evening all over the world. I would like to invite the first presenter in this session, Dr. Constancia Bureta, who is one of our newly graduated neurosurgeons, a very active young lady. Please welcome Dr. Bureta.
Thank you so much, Dr. Zarina. Good afternoon, everyone, and good morning to those whom it's in the morning. I'm Constancia Bureta, and I'm going to present to you on pre-hospital care of trauma patients in Tanzania. Basically, it's a study on the medical knowledge assessment and proposal for safe and efficient transportation of neurotrauma patients.
A little bit of interruption. May I, a little bit of CV from Dr. Bureta. Yes, apart from being a young neurosurgeon, a young female neurosurgeon just arrived from training, she has trained her PhD in Japan at the University of Kyushu. So she has joined the faculty at MOI with a lot of knowledge from the first world in Japan. So Dr. Bureta, please kindly proceed.
Thank you so much, Dr. Ngerageza. Okay, I'm going to present on pre-hospital care of trauma patients in Tanzania. And from this study, we have nothing to disclose. Traumatic brain injury is the leading cause of death and disability in children and young adults during their reproductive years in low and mid-income countries. One important phase in treatment is neurotrauma patients in pre-hospital care, about which little is known in low and mid-income countries. Research articles on pre-hospital care. One of the articles was published by the World Health Organization in 2014, and in this article, they stated that about 5 million patients are involved in neurotrauma, but 1.7 in worldwide. They also, which is almost 1.7 times those that face HIV or AIDS, malaria, or tuberculosis. That means there are more neurotrauma patients worldwide compared to other illnesses. Another journal, that is the Journal of Neurosurgery, which published a paper on the current capacity and deficit in the provision of essential neurosurgical care. In this journal, they reported that majority of the patients that face neurotrauma, neurotrauma in low and mid-income countries, they don't get the neurosurgical care that they should get, especially the intervention and surgical procedures. In the same journal, the Journal of Neurosurgery, in the spine column, in a study that was done in Tanzania, in this study, they compared spinal cord injuries and traumatic brain injuries. And from there, they came out with the conclusion that traumatic brain injury is the leading cause of death compared to spinal cord injuries. And from this, we know that we need to have a pre-hospital care that can help decrease mortality and morbidity. So a multi-pronged approach is needed to improve access to neurosurgical care worldwide. One important and potential fixable area of need is pre-hospital care of patients with neurotrauma. The aim of our study was to assess the medical knowledge and propose for safe and efficient transportation of neurotrauma patients. The method that was used, a descriptive cross-section study was used, and 501 participants were involved. The intended audience was pre-hospital transporters. The survey was prepared in English and translated in Swahili, which is the preliminary language used in Tanzania. Educational interventions such as flyers were made, which were used to help in giving education to the transporters. Statistical analysis was done by the chi-square and univariate and multivariate analysis, both under IBM and SPS statistics. Examination items, 3 predictor variables, educational level, presence of formal medical training, and employment status were used using Chikwa's test. And apart from that, predictors of high score on medical knowledge outcomes were assessed with invariant followed by multivariate logistic regression, controlling for age, sex, and prior experience in transporting a patient. We controlled for age and sex due to the chance of different educational opportunities and prior experience because this could impact the medical knowledge. Results, demographic data. When we asked these transporters about how to improve transport of trauma patients, the most common response was some form of rapid transport, such as ambulance. We can see that 33% of those that responded say they needed ambulances, helicopters, or other rapid transport systems, and other 26% ended up saying an increase in education would help more. We then compared the medical knowledge of the transporters, and when comparing the medical knowledge, about 73% had the ability to recognize sick patients, 71% had the ability to recognize dead patients, but a low percentage of them, about 13 to 15%, would recognize at least 2 signs of dead patients or less than 2 signs of sick patients and deteriorating patients. That means more medical knowledge is needed for these transporters. The difference in medical knowledge outcome, this was assessed based on the 3 variables, the education, formal medical skills, and employment status. While assessing these 3, the pre-hospital transporters with and without formal medical training were able to correctly list more than 2 signs of dead patients. We have a statistical significance of 0.004. And there was a significant difference in correctly listing more than 2 signs of sick patients among all 3 predictors, that is education, formal medical skills, and employment status. Between pre-hospital transporters, those with and without formal medical knowledge, as we can see, there was a statistical significance with a p-value of 0.012, 0.016, and 0.029. We then went forward and assessed if there was a significant difference when identifying more than 2, when these variables were compared, when the transporters could identify more than 2 out of 5 signs of dead patient. And we found out that formal medical training was a significant factor on univariate analysis, where we had a p-value of 0.005. And when identifying at least 2 signs out of 5 signs of sick patients, all the three predictors of education level, that is formal employment status, was significant on univariate analysis. That means in all the categories, at least they could identify that this person is sick. And when assessing the predictors of identifying more than 2 out of 5 signs of clinically deteriorating patients, at this we saw that there was a significant difference in correctly listing more than 2 signs of a clinically deteriorating patient between pre-hospital transporters with or without formal medical training, with a p-value of at least, with a significant p-value of 0.001, as well as with different, as well as when there was a different educational level. We then supplied educational flyers to these transporters so as they can help them in identifying these patients. And the flyers were translated in both Swahili and English, as I previously said. And they had questions. Has the patient had an injury to the head, the neck, or the back? If the answer is yes, then one has to check for the following. Is the patient conscious or speaking? Is the patient moving arms or legs? Does the patient move when pinched? Can the patient feel his or her arms and legs? If not to any of the questions, immobilize the neck and transport to the hospital. On our discussion from previous reports, Londrina, Brazil, and Mason et al., together with Stan, Sen et al., they reported that after implementation of a formal pre-hospital trauma care system and an online lecturer series, also with utilizing fully equipped ambulances, firearms, trained in basic life support, physicians could provide advanced life support. There was a decrease in death occurring before hospital admissions, fewer deaths in the first hour after trauma, and a reduction in motor vehicle crash and mortality rate. So because this is in the developed countries, when we bring the study to the low and mid-income country settings, we have studies that are being conducted in Ghana and Uganda by Mock et al. And Jeremiah et al. These show that a lecture or a course on pre-hospital trauma course, at least for 6 to 24 hours, to the commercial drivers, police officers, and community leaders, resulted in a sustained knowledge and skills and drivers' self-reported improvement in crash scenes management. So this shows us that implementation of a formal pre-hospital system or additional of training in an informal system in the low and mid-income countries improved outcome of trauma patients. Now, the lack of pre-hospital care in the healthcare infrastructure in Tanzania is the main source or the main cause of low medical knowledge of these transporters, and a decrease in knowledge to them leads to an increase in morbidity and mortality. Current implementations that we do, together with our conclusion, it's the pre-hospital training programs, such as first aid classes or pre-hospital care training sessions, or educating aids, such as the proposed flyer that I've just spoken about, and formal medical training, as well as higher education. And lastly, further studies assessing the feasibility and benefits of such programs in Dar es Salaam would be beneficial, as the study would be used throughout the country. Thank you so much.
Thank you, Dr. Bureta. That was a nice presentation. Now we will welcome the next presenter, who is Professor Haitham Hussein. I don't know if he's in the audience.
Yes, Haitham has just joined. Professor Haitham Hussein, I'm more than happy to have you join us to the conference. Happy to have spent good time with you in Alexandria, Egypt, some years back. Please welcome and kindly proceed.
Professor Hytham, we cannot hear you. Professor Hytham. We cannot hear the speaker. I don't know if it is the case with the other participants.
It's only the center or everywhere.
So while we are dealing with the problem with the Professor Hytham, may we call the next presenter? Dr. Ken Kumwenda. Is he in the audience?
Yes, I am, Beverly.
Just a brief word, may I introduce Ken Kumwenda? Ken Kumwenda is a neurosurgeon based in Malawi. He was trained through COSEXA fellowship program. He currently works at the Kamuzu Central Hospital in Lilongwe, together with the visiting neurosurgeon from Ethiopia. In Malawi, remember that in Malawi, there are 3 neurosurgeons for a population of 19 million. Dr. Ken Kumwenda, kindly proceed.
All right, thank you very much, Jafet. All right, first I would like to thank the organizers of this course for inviting me again to be part of it. I'm Dr. Kumwenda from Malawi, as you have heard, and I'm going to talk to you about surgical management of traumatic brain injury patients at Kamuzu Central Hospital. But before we go into the meat, let's just have a brief overview. So Malawi is a beautiful strip of land and lake situated in the southern part of the African continent. It has a population of about 19 million people. It's a low-income country with a per capita health expenditure at $35 US. That is significantly lower compared to our counterparts in the Southern African region. And Malawi also has the 9th highest rate of road traffic accident deaths in the world. It's sitting at number 31 out of 100 countries that were looked at. And this is according to the 2018 Global Report on Road Safety. So we see about 6,000 deaths as a result of road traffic accidents, and obviously a lot more injuries, musculoskeletal as well as neurological, which result in a lot of disability. And Lilongwe, the capital of Malawi, where our hospital is, has a mortality rate that is 7 times higher than the next district. So our hospital basically is sitting at the heart of this problem in our country. And most of these deaths from pedestrians, as you can see on this graph, that 49%, pedestrians, followed by cyclists and passengers of four-wheeled light vehicles. Now, Malawi, as was already described in the introduction, has 3 neurosurgeons that are scattered in 3 neurosurgical centers, 3 hospitals in Zomba, Blantyre, as well as Lilongwe. Now, that's a very small workforce for the country compared to the population. If you compare on the table that's been shared, it may be a little bit outdated, but we still have a long way to go. So at Kamuzu Central Hospital, a 900-bed hospital, we serve a population of over 6 million people. And there's 1 Malawian neurosurgeon, myself. I joined in 2019, and that was the beginning of a formal neurosurgical unit. But we're privileged because we have a visiting neurosurgeon from Ethiopia through our collaborating partners, and they're present throughout the whole year on a rotational basis. We depend heavily also on general surgery residents that rotate through neurosurgery unit, and medical interns also form a big part of our personnel at our hospital. In 2019, when we started, that year we had 380 surgeries that we performed. Most of them were pediatric hydrocephalus as well as a spinal bifida. We did a couple of tumors and spine cases, but trauma emergencies comprised 15% of all the surgeries that we did. So you see on the graph there, on the chart there, that 42% of these trauma emergencies were debridement and elevation of depressed skull fractures, followed by craniotomies done for acute or acute subdural and epidural hematomas. We did also a significant proportion of cases involving soft tissue injuries, the face, as well as at the scalp. Now, in our setting, the average time from injury to surgery is about 12 to 24 hours. This is mainly because we don't have a formal pre-hospital care system, especially in the countryside. We don't have an EMS setup. But the distance from our regional hospitals to our hospital, which is the referral hospital, is about 2 hours drive. So once a patient is being referred, that's pretty much how long it will take them to get to our hospital. Now, most of the delays that we see in decision making at the regional hospital to refer this patient after resuscitating, and also once they get to our hospital, there's time that's lost in being able to acquisition of a CT scan. However, what has sort of improved the situation is a creation of a WhatsApp group on which all clinicians and doctors in the district hospitals are included, and we discuss cases before they refer them. We contribute on the pre-referral management of these patients, and this has improved in the outcomes of some of these patients, and also avoiding unnecessary referrals or unnecessary delays in referrals. Once these patients arrive to our hospital at Kamuzu Central Hospital, it usually takes about 3 hours from the time they reach our A&E to get to the OR, sometimes less or sometimes more, but we have a standby medical team in our casualty that will promptly assess these patients, and they'll consult a neurosurgeon. And we have a dedicated neurosurgery theater, so they don't have to wait before they get into surgery. So as far as equipment is concerned, we have a CT scan in-house, but it's not working most of the times because of frequent breakdowns and then delays in maintaining this equipment. As a result, we have to send most of our patients to a private facility where they have to pay, and it's about $150 US. Most of our patients cannot afford, and so what ends up happening is that we treat most of these patients really without a CT scan. If they can afford, then we send them for a CT scan during those times when our in-house CT scan is not working. And that's one of the biggest challenges that we are facing at our center at the moment. In cases where we need an MRI for spinal cord injuries, we also have to send them to a private facility where the MRI costs even more. And most of our patients also cannot afford to pay for an MRI. We have a craniotome that allows us speedy access to the intracranial space. But sometimes we use the Hudson brace depending on what cases we're doing. We have a regular supply of consumables, Surgicel, drains, and catheters. We have a neuroendoscope. We don't have a microscope, but then both of these equipments are not really required in trauma surgery in our setting. As far as critical care is concerned, we have a 6-bed modern ICU. This ICU caters for the whole hospital. So medical patients and other surgical patients also rely on this 6-bed ICU. But obviously, most of the patients that are occupying the ICU beds at any given time, a majority of them are traumatic brain injury patients. And our average ICU stay for these patients is 18 days. We have a 10-bed adult surgical HDU, which serves as a step-down facility. So after surgery or non-operative management from the ICU, we send them to the high dependency unit. We also have a 6-bed pediatric high dependency unit, which serves the same purpose. We have trained critical care nurses that do a fantastic job in taking care of our patients. We have a team of dietitians and physiotherapists that form a very critical component of our team. We don't have an anesthesiologist or an intensivist, but we rely on our clinical officers or anesthetic clinical officers that are trained mostly in providing anesthesia, but they also are in the ICU taking care of these patients. I should mention, however, that management of neurosurgical patients is primarily done by the attending neurosurgeon. So we are responsible for the decisions and the plans that we make, being at the top of that team and providing guidance. We are working hard to improve the situation, to make strides. We've only begun. There's a lot of work to be done. We're in the process of constructing a specialized trauma, orthopedics, and neurosurgery hospital within the hospital. And it's going to have a dedicated ICU, theaters, rehabilitation, and a fully fledged radiology unit. We hope that doors will open sometime mid next year, and developments are at an advanced stage. We have also started a residency, a neurosurgery fellowship through COSEXA, and with our collaborating partners, we are working to increase the intake and therefore also increase human resource on the ground. So that's part of our team doing one of the surgeries. Thank you very much.
Thank you very much, Dr. Ken. For the sake of time, may I proceed to invite Professor Haitham Hussein? I think you are ready now. Professor Haitham Hussein. Could we then proceed with the next presenter? Dr. Claire?
Yes. I would like to introduce Dr. Claire Karekezi from Rwanda Military Hospital. She's also the first female neurosurgeon in Rwanda, a very active neurosurgeon and the president of the female chapter of the Continental Association of African Neurosurgery. Welcome, Dr. Claire.
Thank you, Zarina. Thank you for having me at this trauma course, and it's a pleasure and honor being here with you all. Can everyone see my screen?
Yes, we can see.
Perfect. So I will share a little bit my experience on ICU management of TBI patient at my new hospital. Excuse me. Great. So I have no disclosures. I come from Rwanda, this tiny country in East Central Africa, which has a 12 million population, is also one of the most dense countries in the region. It has also a very bad past history and has not known any Rwandese neurosurgeon until maybe 2007.
Sorry, Claire, we can't see the screen.
Could you share your screen, please?
Oh, sorry. I thought I shared my screen. Wait. Okay, I'm sharing now. Are you able to see my screen?
No.
No, we can't see your screen. You want to try again?
You have to allow me because I cannot share. So, host disabled attend screen sharing. No.
1 second, we have to make you a co-host.
Yeah.
Okay, you should be able to share now. We apologize.
Okay. Oh my God.
We can see your screen, but not the slide presentation.
But that's not my screen because I'm saying I'm viewing Chumemwe screens. I don't know. Okay, let me try again. I'm unable to share my screen. I don't know why. No. Maybe someone has to help me. I don't know.
Someone can help her. And she's continuing presentation.
Brandon, are you there? Do you have her presentation?
Oh, Claire, this is Beverly. If you could email me a presentation, I can download it and upload it.
Okay, perfect.
I don't see the presentation uploaded. I'm sorry.
No, send it. Let me send it to you. Well, maybe you can proceed to the other presenter. I'll come back.
In the meantime, Dr. Shabani will proceed.
A little bit about Dr. Shabani, our boss. Dr. Shabani is a very, very senior neurosurgeon at MOI. He came back from Nagasaki, Japan, where he trained his neurosurgical training in a doctorate degree program, and joined the forces that existed by then, joined Professor Kahamba, and started and continued all the efforts in neurosurgical training and developing neurosurgery program at MOI. So most of us, we have grown from MOI, but then Dr. Shabani has participated in the course of training and developing our career. May I take this opportunity to invite my boss, Dr. Shabani.
Thank you very much, Japhet. I'll go quickly because I know time is not on our side. I am supposed to present the value of TBI registry in changing practice and improving outcomes. So I will just show our experience at MOI and the starting point be with Weill Cornell. But before we go there, I think everybody knows what is Kaizen. This is a quality improvement program inherent in the Japanese corporate culture. And in fact, Kaizen is even beyond the corporate culture. It is inherent in their lifestyle, and it is taught by mothers to children. And what it entails, it is whatever action you are doing, you have to sit back, reflect, see how best you can do it, and you continue doing it. And if you don't do better, you are exiled from the community. This is how it is taught in Japan. In Kaizen, as a corporate, I think they go the same way. Execute, assess the problem, review, give feedback, and then continue again, execute, reassess, continue, and this goes on and on and on and on. And we have adopted that one. If you remember, when I came back from school, this is how I found the ward in the hospital. Remember, the hospital had only 2 neurosurgeons. One had already involved in the administrative duties. So there was only one practicing neurosurgeon at that moment. The hospital, the ward was densely packed. Severe TBI patients were very far away from the nursing cubicle. And there were no ABC protocol as per Brain Trauma Foundation guideline. And brain CT scan was not affordable. Very few could get brain CT scan at that time. And each monthly meeting about mortality, severe TBI was ranking the first. In 2007, 2008, we adopted endotracheal intubation for all severe TBI patients. And this was after a small group of doctors who were sponsored by FIENS visited us and introduced the protocol. But at this moment, the comprehensive TBI registry was not yet started. But still, we were experiencing the same trend of mortality, but the only difference was the caregiver knowledge, attitude, enthusiasm had improved. Remember, at that moment, any severe TBI patient coming to the hospital, well, everybody knew what was the prognosis, that he is destined to die, and whoever was taking care of those people were called neuros. You know? The neuros means people who do things with a poor outcome. So the TBI registry started officially in 2014 after signing the collaboration with the Weill Cornell Medical College and Professor Hato and Professor Mangat. And it enrolled all the BTF Brain Trauma Foundation guidelines. Resuscitation, pre-hospital care resuscitation, and all the fluid surgeries and CT scan. and the patients were assessed until day 14. We use the same resources as you have seen there. The emergency department operating room, which was shared with the orthopedic surgeries, the ICU, which was only 8-bed ICU, and the outreach CT scanner. And the quality improvement program also involved the annual Tanzania Neurotrauma courses from that moment. We employed 30-bed ICUs and step down in 2017. At that time, the separate emergency ICU also for TBI patient was also inaugurated. And at that moment, the number of surgeons also increased, plus other supporting staff, which I'm going to mention later. So this is the TBI database. We uploaded our data in anonymous matter on the website, the TBI track, which is funded by the Brain Trauma Foundation. And until December last year, we have recorded 579 patients, severe TBI cases. And inclusion criteria is listed below. Categorically, severe TBI patients with GSS less than 9 after resuscitation. Those were the patients who were entered into this. And the most important thing, to exclude the pre-hospital causes of mortality, we fixed our entry point at not more than 48 hours since the onset of trauma in these patients. CT scan was recorded, surgery was recorded, personal data was also recorded, and factors of mortality were recorded systematically according to the Brain Trauma Foundation. So I will share with you few slides, the analysis. The 2-week mortality trend from 2014 until 2018, as you can see, remained consistently high at 64%. Then we did regression analysis, and we found the blood pressure issue was important, and we focused our protocol on the hemodynamic monitoring. So in the new ICU, we reinforced our hemodynamic monitoring. This is the ICU which we have right now with all these facilities. We thank our government for sponsoring this. For hemodynamic protocol, it was important that continuous monitoring should be emphasized. So we meant to get 3 anesthesiologists to lead the team and monitor the ICU activities. And also we employed our residents 24/7 in ICU and HDU. And daily ward rounds were done in multidisciplinary manner. The neurosurgeons, anesthesia team, the nursing team, the physician, the physiotherapist, nutritionist, and at each round, some form of skill session was done in collaboration with our visiting fellows from Global Neurosurgery Program. I've mentioned about the CT and MRI already, so and the separate therapy. So this is how you can see things being done to ensure the quality improvement on daily basis. So attendees could get training half an hour every day. in the morning, immediately after the round. Our data trend, if we continue again, you can see most of our severe TBI patients were young males, and admission consistently from 2014 was consistently the same, 87, 100 and something, almost between 80 and 70. And the data which I couldn't share with you is that the severe TBI constituted only 10% of all traumatic brain injury patients who received at this period of time. Mechanical ventilation, immediately after we employed the ICU, the new ICU where all patients were admitted in 2018, you can see the mechanical ventilation jumped up from 50% to almost 100%. And the CT scan coverage also improved. If you compare the 2017 and 2018 data. The surgery also improved. If you compare the 2017 and 2018, 2019 data, you see the surgery also improved. Regardless, the number of the surgery, the number of severe TBIs was the same, but we managed to improve our procedures, we improved our procedures because of the ICU availability, CT scan, diagnosis, and more staffing. And this one, if you compare right now, the mortality, you can see here, the bar chart, the 2017 vis-a-vis 2019, you see the mortality decreased from 64% to 42%. This is what we boast at MOI, that quality improvement program through the Kaizen way can improve outcome of TBI, of severe TBI. So in conclusion, we believe this method is feasible for low and medium income countries. The role of multi-sectoral approach and international collaboration is indispensable. Quality improvement using TBI registry is a continuous process, the Kaizen way. So this is what I can remind my fellow colleagues who wants to emulate our success. Thank you very much.
Thank you very much, Dr. Shabani. Could we have time now for Dr. Claire to proceed? Dr. Claire, please, if you kindly proceed now.
I'm sharing my screen now. Are you able to see my screen?
Yes.
Perfect. Sorry for the little trouble. So thank you for inviting me. It's a pleasure being here at this course. And I'll be presenting on our ICU management at the Rwanda Military Hospital. So I have no disclosures. I come from Rwanda. It's a little tiny country in East and Central Africa. It's also one of the most dense countries in the region with 12 million population. We have the beautiful city, Kigali, our capital, gorillas, coffee, and hills. So you are welcome to visit us anytime. We have come a long way. I would say that until 2007, we barely had a Rwandese neurosurgeon. So all neurosurgery was provided by visiting neurosurgeons coming from everywhere. We had some who came from South Africa and some who came from Cuba. But since 2007, the first neurosurgeon came from China, and 2008 we had a second one who came from South Africa, and they were able to initiate a local training, and they started different departments. So up to now, to 2020, we have 6 neurosurgeons We are all located in the capital city, Kigali. We work in 3 main hospitals. King Faisal Hospital is the main leading hospital. Then we have the Kigali Teaching Hospital. And I started the Department of Neurosurgery last year at the Rwanda Military Hospital. So the Rwanda Military Hospital covers the whole eastern part of the country. It's about 3 to 4 million population. And you can see that the whole country actually drains to Kigali. So every neurosurgical case will eventually come to us. So also particularity so that the King Faisal Hospital is a sort of semi-private. So all the public population or public cases will mainly come between the teaching hospital of Kigali and the Rwanda Military Hospital. So in the country, we have now up to 6 to 7 CT scanners. We have 2 hospital MRIs and 1 in private. So as I said, we're 6 neurosurgeons and we work 2-2. So until last year, when I started in January 2019, I worked alone for 12 months. And in December, I was joined by a colleague who locally trained here. So we are 2. So you see that the country serves 12 million population, but we also serve part of Burundi, DRC, some pathologies drain to us. So until last year in January, Rwanda Military Hospital had just neurosurgical consultations, but no surgery was actually done there. And I was able to initiate this department with, in the beginning, little instruments. And my initial cases were mainly trauma cases, barrels, epidurals, and then progressively I started doing bigger cases. So I will talk more about our ICU capacity. So at the national level, before the COVID crisis, we had a capacity of less than 50 beds. King Faisal leading with 7 ICU beds, with 7 HDU beds. Kigali Teaching Hospital, about 7 ICU beds and 3 other pediatric beds. So RMH, where I work, we have 8 ICU beds, 3 beds with HDU capacity, and all the beds are for all specialties. So general surgery, OB-GYN, everything, like any patient needing ICU, we will have to share those 8 ICU beds. So the Butare Teaching Hospital is in the southern part of the country, 2 hours from Kigali, has about 5 beds of ICU. But with the COVID crisis, we have increased our bed capacities, and we've gotten more ventilators, but there's still a need to increase the number of course, ICU doctors and nurses. So this is the ICU at the Rwanda Military Hospital. As I said, we have 7 to 8 beds. We have 4 emergency physicians, but this one, they work at the emergent department. And we have luckily 4 anesthesia and critical care specialists. So these help us, and they're the ones that run the ICU. They have about 7-8 specialized nurses. And you can see these are all shared beds. So there's no clear separation. And any patient needing ICU will eventually come there. So since we started, our neurosurgical activity is mainly has mainly been marked by trauma cases. We were able to see so far more than 3,500 patients. I started with really no dedicated team. I was the only neurosurgeon until December, so we are 2. We had no resident. We just worked with ER GPs and ER physicians who helped us managing the patient at the ER. So we had no dedicated ward beds as well. And we had to share with all the beds of surgery. So general surgery, urology and so. But I was at least able to request that some rooms be dedicated to neurosurgical patients, just to avoid mixture of infected patients with our clean patients. So we had no dedicated, and we still do not have dedicated ICU beds. So all beds are shared. So we have 1 day each of elective surgeries, and we have about 2 days each of consultations. So eventually we started seeing more tumor cases, and we have done quite a good number. So we see all kind of TBIs, and I would say that we see mainly chronic subdural hematomas, acute epidural hematomas, and acute subdural hematomas. Unfortunately, I think most of acute subdural hematomas, they are victim of delays between being evacuated to Kigali and having a proper CT scan and being taken care of. And sometimes it's a little bit too late. So, and we have a lot of brain contusion, penetrating brain injuries, depressed skull fractures, so all kinds of injuries. So what's our ICU management of severe TBI? So the management starts usually at the ER department. And these doctors are really used to communicate with, so as I said, we cover the eastern part of the country. So the doctors at the district levels will eventually call, because now we have some hospitals that have access to a CT scan. Whenever a patient has TBI and has had a CT scan, we'll contact either me or my colleague or either the ER doctor. And once we see it's a surgical case or it's a patient who needs to come to us, we will grant, we allow them to take him to us. It takes up to maybe 3 hours. The time they get to us, some patients have already their CT scan. Those who do not have CT scans will have their initial evaluation and resuscitation by our ER doctors. And the CT scan is done in our hospital as soon as possible. And depending on the type of injury, we like to proceed with either if there is an epidural hematoma compressing, if there is an acute subdural hematoma, depending on the GCS on admission, then we'll admit the patient in the operating room. So we do not have a dedicated neurosurgical OR, but whenever we have an emergent case, they really help us getting a room, and they have, before we started, they weren't used to this, but now they have been seeing us operating many times, so they know how urgent our cases are, and they eventually give us a room or a spot. So the main issue remains the ICU spot. So not all cases will get an ICU bed. So by the time, for instance, you get an acute subdural hematoma who needs an ICU, you may operate on him or her, and she doesn't not get an ICU bed. And it has happened that we leave patient on the operating table, on the machine until we clear a bed for them. So it's a little bit tough on us, but yeah, we try to get beds for them. And when we do not have beds for them, sometimes we discuss that the patient do not come to us, because we know when those doctors are referring them to us, calling, they tell us the GCS. So when we see that we do not have an ICU bed, we try to communicate with the other hospitals to see if they can be taken there. So as you see, we like to operate on them and then eventually admit them in the ICU. We have the initial injuries, and especially admitting them is to avoid secondary brain injury. So what happens there? what happens there is our ICU is run by our anesthesiologists, as I said, but we collaborate closely with them. Patient get the general ICU monitoring, and we do not have ICP monitoring, invasive or non-invasive. We do not have access to any of these. So I prefer, if these are patients I've operated on, I prefer maybe for 8 hours analgesia and sedation, and eventually, of course, they are intubated if they have a GCS below 8. Otherwise, they will not allow me to take a bed for a patient who is not intubated, knowing that there is another patient who will need that bed. If they are borderline, they do not need intubation, I leave them at the ER. If they need intubation, that's when I take them to the ICU. If I have operated on them, I keep them sedated for 48 hours, and then we wean slowly, and I try to get at least a clear physical examination, neurological examination, evaluate the pupils, and try to get a 48-hour CT scan. And then if it's a patient who can be eventually extubated and supports that very well, they expect him, and as soon as he's fit to go to ward, I take him out of the ICU because they are in need of beds. If it's a patient who cannot or who fails the weaning process, and there is nothing to be done depending on the CT brain control, I try to keep them sedated, and then eventually plan an early tracheostomy from day 5 and keep the weaning process. So the idea is to get them out of ICU as soon as possible. So we've had patients who are able to breathe with the tracheostomy, and who remain vegetative. So those ones, I take them on the ward because they need to clear the ICU beds. So it's a little bit challenging. The capacity is low, and we have really no coordination at a national level. It's just communication between different hospitals, and at a national level, beds are still very few. And also we lack a comprehensive database and clear guidelines, and where the TBI patient go, and what to do for them. And we lack the part on ICP monitoring, and there is no clear guidelines as well on when to withdraw care, when to say that the patient is brain dead. So sometimes we just wait until they are really like dying, and to get them out of ICU. Sometimes we may decrease care, but I think it's not supported by the law. So you need to give the care as long as the patient is still breathing. So to answer to the questions that were asked, what resources? As I said, we have access to 8 ventilators, we have some monitors, space, few beds, 8 beds, 3 HDU beds, 4 anesthesia and critical care doctors who help us. And who gets care? I believe everyone who is in need should, but not everyone gets care. So we try to do our best. And who runs the ICU are those critical care doctors and us. Thank you.
Thank you very much, Dr. Claire. We are running very short of time. Could we have Professor Hytham? Are you available, please? Professor Hytham? Professor Hytham from Sudan?
I think we continue with the next presenter.
Dr. Beverly?
I think Haytham is trying to log on. What we can do just to save time is I can reschedule mine to the 22nd because we've run past 8 p.m.
Okay, let's hope Professor Haitham will manage. I think Professor Haitham is muted. Can someone unmute him?
Is he
Professor
with the
Haitham?
MOI presenters?
He's just trying to unmute just now. Just give him a moment. Apologies from Dr. Haitham. We're having technical difficulties, and we'll try and reschedule his talk. So maybe we wrap up, and then we'll meet again.
Okay, so I would like to take this opportunity to thank everyone who showed up and to thank all the presenters. There is a post-course survey that the participants will be required to fill. And if there's nothing else, we'd like to call it a good evening.
I'd like to, on behalf of Cornell and all our team, like to thank our hosts at MOI, but everybody else who's attending in the middle of Sunday. Thank you very much, and I hope this is a useful course, and you will come back on the 15th and 22nd as well. 15th is dedicated to spine trauma and 22nd to research.